So, good morning. Welcome to all of you for this second topic in Oman Hall. What is new in pediatric ophthalmology? So, for this session, we have got an esteemed guest speaker, Dr. Sumita Agarkar from SN Chennai. Madam is currently the Director of Paediatric Ophthalmology at SN Chennai, and her contributions to the cause of pediatric ophthalmology are immense, all of you know. And if we start describing her, so like in the last session, like Mohan Rajan sir was described, if we start describing, there will be no end to it. So I think all of you, many of you might have gone through the current AAOS Times book. So if you haven't gone through that, please go through it. The first topic in that AAOS Times news book, it's not a newsletter, it's a news book, and that conversation with the legends. And the legend discussed this time is Madam. So one of her favorite fellows had an interview with her, and if you go through it, you will get a glimpse of what Dr. Sumita Agarkar is to pediatric ophthalmology. So a warm welcome to you, Madam. And in this session, we have also got our own Dr. Rashmi Bhaskar talking on newer things in amblyopia, and Dr. Chaitanya Warrior, she is talking on newer things in visual assessment of children, and Madam Sumita Madam will be talking on the myopia control glasses, which all of you would be eager to hear, and also the low dose atropine and myopia, which though it's in the pediatric ophthalmology regime for quite a few years now. Where do we stand as of the pediatric ophthalmology? These are the two topics which will be covered by Sumita Madam. So as for myself, I think though it's titled What is New in Pediatric Ophthalmology, in 55 minutes we will be able to cover a minuscule of what is new in pediatric ophthalmology. And apart from the three topics being discussed with the three guest speakers, I think I will touch upon the few other things which are new in pediatric ophthalmology. So the in thing in pediatric ophthalmology, if you want to discuss, would be the gene therapy. So we have FDA approval and FDA guidelines in gene therapy for RP, Leber's conjunctival and a few inherited retinal disorders. But the problem is, though we have gotten railroading into conditions like RP, even though we have gotten FDA approval for a few drugs in gene therapy, the good thing is that we have got an initiation into the gene therapy. But the other part is that even now the FDA approved drugs, they cater only to a small percentage of RP patients who have got a specific genetic mutation. So it doesn't cover the whole RP spectrum, but anyway, we know that we have something to offer. And the results of gene therapy, as for we have done, it shows that younger age children who are into this therapy, they get better visual improvements. But as we stand now, we doesn't rule out the procedure in adults. And the Pediatric Eye Disease Investigator Group Network, which has done a lot of studies in the pediatric eye disease segment, and they have evolved a lot of changing patterns in the treatment of amblyopia, strabismus, childhood glaucoma, congenital cataract, NLD obstruction, anti-VEGF in ROP, etc. So if we look at where do we stand in ROP as of now, the recent criteria for predicting ROP for neonates with different birth percentiles have come in, and also the international classification system of ROP, which is in place, has been updated. This updation has happened because of the newer things that we have found in ROP, updation we have got on ROP, and also with more of anti-VEGFs being given, there is a slightly modified changing pattern in ROP that has come in. So all this has led to an updation in the international classification. And also in ROP, there has been an accelerated use of telemedicine in almost all the states. If you look at what is new in strabismus, traditionally, when we talk about an extraocular muscle and its movement, we talk about the extraocular muscle starting from its origin to insertion, how does it act. But the active pulley hypothesis, which has been put forth by Miller, Demmer, Clark et al., it has been found that they have proposed that there is an connective tissue network which is called as a pulley, and it has been found that it has been hypothesized that the extraocular muscles have got an orbital layer and a global layer. And they have hypothesized that the orbital layer inserts into the connective tissue pulley rather than into the globe. So, understanding this pulley hypothesis or getting involved into this pulley hypothesis, we have got, if we understand this pulley hypothesis and if we work upon that, we have found that the physiology as well as the pathology of the extraocular muscle action and many of the pattern strabismus things have changed a bit, and this is being updated as of now. And another thing in squint, it has been found that the injection of bupivacaine, which we use as a local anesthetic, if you inject bupivacaine into the extraocular muscles, it induces a cycle of myotoxicity, degeneration, which goes on to regeneration and hypertrophy of the muscle fibers. So the net effect is, when you get in hypertrophy of the muscle fibers into which you inject bupivacaine, what happens is the effect produced is something like the resection that you have done on the muscle. So it just pulls on. So in a case of small angle esotropia, if you inject bupivacaine into the lateral rectus, this resection effect produces small corrections. So this is something which is rather new in squint correction. And Scott et al. Proposed that bupivacaine injection into the horizontal muscle which you plan to resect and Botos injection into the horizontal muscle which you plan to recess will correct reasonable amounts of squint. This is something called as an chemical resection recession in a squint. And this slide again is also about a word about genetics. Why genetics is important? Because most of the other things we are rather taken care of. But genetic and inherited disorders, we are still at a loss. So most of the inherited genetic disorders, not only in the eye, but otherwise, they are called ciliopathies. And it has been found that nonsense suppression therapy. So all these genetic disorders, they happen because of abnormal mutations, nonsense mutations. So if you have gotten therapy targeted at these nonsense mutations, which suppresses this nonsense mutation, you can have a cure for or treatment for these ciliopathies which produce inherited retinal disorders. So we have gotten better understanding of the neurophysiology of vision, and we have found that in nystagmus, a simple surgery like tenotomy and reattachment of the muscles in the soginal site for nystagmus produces results, and selective endothelial removal for congenital corneal opacification is coming up in a big way. Even neurotization of the anesthetic cornea for corneal hyposthesia and aesthesia. But in spite of the advances being made in the diagnosis, treatment and understanding of the visual system, the advance to this advanced treatment care will be maybe in 1 or 2 decades. Still we will be, because of the cost as well as the universal availability of these newer things, we may not be into these routes in a big way in the coming few years. Maybe in 1 or 2 decades we will be into this. Thank you.
Next our talk will be by Dr. Chaitanya regarding the newer methods in vision screening in preschool children.
Good morning, Manandor. I would like to thank Dr. Sasanaman sir and KSOS for this wonderful opportunity. To begin with, newer methods of vision screening in preschool children. Here, I have put 3 different colors for 3 different words because these 3 different words have its own importance. It's newer methods and it's only vision screening and for preschool children. As all know, visual system of children are immature and we need to tackle all the abnormalities early to restore the normal vision and to prevent amblyopia. Vision screening can be for the 2 things to rule out the vision related abnormalities and potential eye issues. Can be done as all know through many modalities like community screening, preschool, school screening and even at the medical professional level. So many studies have been done and pediatric screening can be done by subjective screening or by objective methods also. Subjective screening we are using conventional methods and the newer one is computerized techniques like one is Vision Quest 20/20. Here we can use visual acuity measurement, depth perception, color vision and we can also use the data management. Here the iSpy 20/20 software is there. It will be using different video assisted games that will not be memorizable by the child. So it will give you a pass or fail certificate. If it is fail, the child will be referred to the ophthalmologist for the further evaluation. And MNS Smart System is there based on Smart System tablet. And another is JVAS, JIP Visual Acuity Screener. It is a computerized vision screening freely available in using this online. And based on the computer testing, we need computer and all the distance should be adjusted. Here, as per the VIP study, JVS has high sensitivity and same specificity. It is also very useful for the preschoolers and younger children. And coming to the objective screeners, which is the most common modality for screening, is basically auto-refractive screeners and photo screeners along with VEP measurement and artificial intelligence. Here, the advantages is less input from the children and faster, useful in preschoolers. Auto-refractive screeners will estimate the refractive error in each eye separately, provide pass or refer results within seconds. Advantages, it is quick, easy to use, helpful for young children. But the disadvantages is one eye at a time and limited detection of strabismus, no visual acuity measurement, it is only a screening and structural lesions are not identified. Few common auto-refractive screeners are sport vision screener, and it is demonstrated an overall sensitivity of 0.88 and specificity of 0.78 for autorefractive screeners. SureSight is another common use. Sports screener, the advantages is user friendly for younger children and can also use the red reflex to detect amblyopia. SureSight screener is little robust, need little cooperation and only for refractive errors. Retinomax series, many different series are available. Extended measurement range we can use, fast and reliable and even for small pupil and child friendly. Coming to the photo screeners will take images of corneal light reflex from child pupil, perform binocularly and even in undilated pupil can detect refractive errors along with a few structural pathologies. When to do photo screening? Usually not before 1 year because poor fixation behavior impedes measurement, false positive rate is high and there is low likelihood of ophthalmic intervention and sometimes the refractive error correction if not gross will be delayed. So many studies were there regarding the photo screeners used in vision screening. 2 light sources are used, basically one visible light or the infrared rays. Visible light is used in MTI screen, VISIS screen and eye screen. Infrared rays are used in plus optics and sports screeners. Eye screen is the one of the first generation and the reason one is eye screen 3000. A blinking fixation light and sound will attract the child's attention. MTI photo screeners is not it's little older, no new machines are nowadays made. Plus optics is the newer one. Infrared video recorder to obtain images in 3 axes. It will trigger referral if one eye is more than deviation 10 degrees. Squinting is also, it will refer. So many newer variations are there along with one S16 stationary vision screener is there. It is designed to screen for refractive error, anisoscoria and strabismus in children starting at age of 6 months, even at 6 months. Along with autorefractor screeners is also there in the plus optics range. Optec 5500 is another series vision screener. 2Win is also binocular objective refractometer. GoCheck Kit is a newer app, can be used in iPhone. It's for just screening even at the by medical profession or family physician. It is useful to screen vision without the help of ophthalmologist or optometrist. It can be used through iPhone. Blink or birefringent scanner is helpful to detect the amblyopia directly, and it is also having one importance. It will help to detect very micro strabismus, that is even up to 1 degree micro strabismus can be fixed. With the usual, our eye can detect 6 degree strabismus, and with the photo screeners only 10 degree. Here the blink will be helping to detect even 1 degree micro strabismus. And also VEP vision testing system will be helpful. This is a child friendly VEP method. And so many studies have done to compare all these vision screeners, and vision screeners market by 2030, it will be leading to play a very key role for the vision screening for preschool children. Thank you.
Amblyopia is a very, very important, and I think even if you don't deal with children, I believe that everyone should know how to deal with amblyopia. So Dr. Reshmi is going to enlighten us with newer methods of amblyopia treatment.
Thank you, ma'am. Good morning, everyone, and my topic is what's new in amblyopia treatment. No financial interest or affiliation to any of the product mentioned here. Amblyopia is a disorder of neurodevelopment that results from inadequate visual experience during the early years of life, that is during the critical period. It's the most common cause of monocular visual impairment in children. For a normal visual development in a child, you need a visual stimulation, ocular alignment, and a clear visual image. If any of these is disrupted, it will result in amblyopia. We know that the amblyopia causes a decrease in vision as well as a decrease in contrast sensitivity. What are the functional consequences? There is a fellow eye deficit in the form of impaired motion perception, fixation instability, and 25% slower reading than the peer group, and impaired motor skills like poor hand-eye coordination, and all this is going to affect the quality of vision and life of a child. Awareness and screening is the first thing in case of amblyopia treatment. The neonatologists, pediatricians, and all healthcare professionals should be aware of the condition and start early screening and detection. At the time of birth itself, the retroflex can be checked and external eye for any other abnormality. All preterm children, in addition to having an ROP screening, should have a refraction and squint evaluation at 6 months of age, and here a follow-up after that. And those with a family history of refractive error, squinting, or amblyopia should have early screening. With all the newer advances in screening methods, like already mentioned by Dr. Chaitanya, all children before they start their schooling should have a vision test done. Coming to the amblyopia treatment, it will start with the correction of the refractive error or squint if any, and correction of the visual deprivation factors. Refractive correction alone will solve the anisometropic amblyopia in 27% patients, and for bilateral refractive amblyopia, 74% achieved best corrected visual acuity of 20/25 with glasses alone. Even in strabismic amblyopia, 32% had a full resolution with glasses. Coming to amblyopia treatment, we can divide it into monoocular or binocular. Monoocular treatment, what we know is about occlusion or patching, atropine penalization, and Bangerter foil. Atropine, regarding the patching history, it starts from around 900 AD, and it has been continuing from 16th century for treatment of squint. And till now, patching or occlusion therapy is a main important thing for all patients for amblyopia treatment. Different types of patches are available, like those adjacent to this directly, which is adherent to the eye, or those worn over the spectacles, and depending upon the creativity of the parent, you can see different methods of patching. So whatever we know that the patch is still our all-time hero. Coming to pediatric studies by the amblyopia treatment trials, patching is effective. For mild and moderate amblyopia, 2 hours of patching is equivalent to almost 6 hours of patching, and severe amblyopia, 6 hours of patching is equivalent to full time. And up to 17 years, patching alone has been shown to have improvement if previously not done any treatment. Disadvantage is poor compliance, skin allergy, and you need a good parental support. With a new academic career and all, they don't find time for patching at all. And in some cases, they have occlusion-induced amblyopia also. The new thing in this patching is monitored occlusion. There are few sensors attached to the behind the patches by which you can directly monitor the compliance and number of hours of patching. Intermittent occlusion glasses, that is a liquid crystalline glass that we can set the timing of occlusion, that is the glass will suddenly become opaque without the child knowing, and you can set the eye and also the hours of occlusion. But because of its high cost, it has not gained much popularity. Occlupad or occlutab, by removing the polarizing film layer from the LCD screen, the amblyopic eye will be able to see through that, and the fellow eye you are given neutral density filter. The new perspective in amblyopia is treatment of amblyopia outside the critical period. We know adult brain can learn after injury. So the plasticity at the cellular, synaptic and cortical level is the one that is preventing the amblyopia from improving the adulthood. Certain factors like intrinsic and extrinsic factors that change the plasticity, then amblyopia treatment can be given to adults also. The second important thing is amblyopia is a binocular disorder. We now know the higher order functions are affected in amblyopia. So the treatment also has changed from uniocular to binocular level. Binocular therapies are two types actually, perceptual learning and dichoptic training. So what is perceptual learning? It means if you repeatedly do a thing, that can produce a change. That is, practice makes perfect. Perceptual learning is based on visual stimulation and neural plasticity by targeted visual exercises. You keep on doing like number recognition, contrast identification. These when you do repeatedly, it can cause a change in the plasticity. Disadvantage is boredom. If you repeatedly do the same thing, they will get bored. And improvement in specific task only. Revitalization is one such which is based on perceptual learning. Dichoptic therapy, it is based on giving two independent stimuli to each eye, and you increase the signal in the amblyopic eye and decrease the signal in the fellow eye. So when the child uses both the eye only, they will be able to play. Different types of dichoptic therapy are there, and the child uses anaglyphic glasses, and they are doing high contrast is given to the amblyopic eye, and they play the games or they watch movies. They can do it in tablet or computer screen. It can be home based or in hospital based. Few studies have shown that they show an improvement within a shorter period, but long term, not much proof. Orthoptic is a magnocellular stimulator by our own Dr. Santan Gopal sir. Depends upon the top-down impulse, and it depends on the stimulation of the attention mechanism. The child will be counting the number of lights in the periphery or the lights that is shown on the screen. Now the new thing is a virtual reality games. That is, a child uses a VR headset, and they will be two images will be given to them. You can adjust the contrast of the image by increasing the contrast or decreasing the contrast. And the new amblyopia trial study has shown that VR game of 1 hour, 6 days versus 2 hours of patching. The results are yet to come. What are the advantages? It improves the vision, stereopsis and binocularity in a shorter duration and better compliance as the kids are easy to play. And the disadvantage is cost and balancing the therapeutic with the digital media and screen time. Because once they started doing the games and all, later they can go for an addiction to it. And it's not suited for dense amblyopia and very young child. Coming to pharmacotherapy, two drugs which are commonly used are levodopa-carbidopa combination, which increases the dopamine level, and citicoline also. It increases brain metabolism and increasing the norepinephrine and dopamine in CNS. The studies have shown that citicoline with patching has shown better results than patching alone. And levodopa for the residual amblyopia is also under studies. Another new thing is transcranial magnetic stimulation. By stimulating the occipital, it will change occipital cortex with the magnetic stimulation is shown to change the plasticity and work in adult amblyopia. So the take-home message is early screening and detection of amblyopia plays a key role. Correction of refractive error and amblyogenic factors is essential. Patching still plays a very major role, and amblyopia have a role beyond the critical period. Dichoptic therapy can be combined with patching for better rest, and with the ongoing researches, we hope for an ideal and better method that can be applied for all ages, severity, and types of amblyopia. Thank you.
So, thank you, Dr. Rashmi. And so, still, we have been talking about occlusion in amblyopia for many decades now. Still, it holds good, but we have come a long way in how we manage children with occlusion. And the other good thing has happened in the recent years is We have all these things. With children, the problem is to make them do these exercises. Now that all these things have become playful, things have become easy, and the management scenario of amblyopia is totally changing over the last few years. And next we have our guest speaker, Dr. Sumita Agarkar, madam. She's talking on two things. One thing is atropine myopia, the present status, and also back to back she will be talking on myopia controlled glasses as well. Over to you, madam.
Thank you so much. Thank you to organizers of KSOS for inviting me. And I always enjoy coming to this meeting because usually there are lots of questions asked and people are interested in listening to what we have to say. Thank you. So atropine is not really new. The first atropine studies, first recruitment for atropine studies was way back in 2004. So we have now probably a cumulative evidence of how atropine is working for past 20 years. And why are we still talking about it? Because it is an increasing prevalence. And if you see India somewhere here, there has been from 6% prevalence in 2003, we are touching around 25% in India, and that is not even accounting for COVID years. So in 2010 to 2050, there is a massive increase, and it is projected that 48.3% children are likely to be myopic by 2050, which is a alarming figure. If you look at the so this is our data. This is a STEM Shankar Netralaya STEM Tamil Nadu SLR study, and we found almost 25% children, 17.5% in urban and suburban children in Tamil Nadu were myopic, which is a huge increase from our own school data earlier. So like winter is coming, myopia is coming. And why it is important to, because myopia is not just spectacle alone. If it was just spectacle alone, we really shouldn't bother. Okay, we give spectacle and that's the end of the story. But myopia also comes with an increased risk of complications like myopic maculopathy, glaucoma and retinal detachment, and the risk increases from as there is a dioptric change. As you can see, maculopathy risk is around 2.2, which increases to 9.7, and if it is more than 6 diopter, there is a huge increase in the patient's probability of patients developing maculopathy. Same goes for retinal detachment, both of which are visually disabling condition and require a huge amount of expert care, as well as economics is also daunting managing these conditions. That's why every diopter counts. However, when we look at myopia control options, it's important to remember we are treating progression and not myopia. So everything is designed to look and control progression and not really the myopia. Myopia correction is still, treatment is still giving a pair of glasses, but if the progression is there, you should probably target, your target should be the progression and not really the myopia. So who needs intervention? Generally, any progression of 0.5 diopter or more over a year, if you see, then I think you should look at it. Axial length elongation of 0.1 millimeter or more, because most of the complications of myopia are related to how long the eye is. So axial length elongation also becomes a part of your myopia workup, not just cycloplegic refraction. And also you have to look more carefully at children who are at risk of progression, like if there is a parental history, lifestyle, sleep patterns, these should be included in your algorithm about deciding who needs progression, who needs intervention. So these are all the things which are available at us for us to use. You have pharmacological agents, you have optical devices, you have specialty contact lenses, you have combinations. But most important, and we don't talk about enough, is lifestyle modifications, which we should take 2 minutes of chair time to explain about these. So these are the pharmacological agents, and my talk is on myopia. So apart from atropine, I'm not going to talk about rest of the two because they are theoretically they are effective, not so much 7-methylxanthine, but pirenzepine, but they are neither available nor they are applied to our country per se. So initially, effect of myopia on atropine on myopia was supposed to be an effect on accommodation, but now we most likely postulated mechanism is that its effect on modulation of the dopamine release. It functions at a relatively low dose via a neurochemical cascade, which begins and at M1 to 4 receptors in retinal amacrine cells. So what atropine does is it binds to these amacrine cell receptors, leading to a release of dopamine, which acts like an inhibitory influence on the elongation of the eye. It is postulated that atropine can also have a direct influence directly on scleral fibroblasts and interfere with the scleral remodeling associated with progressive myopia. So direct effect on sclera by inhibiting glycosome and glycan synthesis via a non-muscarinic mechanism is also postulated. Now important thing to remember is that despite all these postulated mechanisms, we still have a slight gap in knowledge about what atropine is actually doing and whether this has any long-term effect on these children, which is visible 30 years down the line or 40 years down the line. There is a little gap in knowledge here about exact mechanism of action. How effective is the atropine? Well, we may think that atropine started with ATOM studies, but actually the earliest studies using atropine were way back in 70s and 80s. And the first two randomized control studies had already demonstrated, which I have mentioned here, had already demonstrated a 60% or more decrease in the reduction. But these trials were often not gained traction because one, there were a lot of dropouts, and second, there was never a control group in these studies. So despite hype about myopia after atropine, but actually people were looking on this the work had started much earlier. Then of course came ATOM-1 and ATOM-2, which were much better designed trials because they were randomized, they were prospective, and they had a control trial, they had a controls. So they included 400 children, and myopia of 1 to 6 diopters, and ATOM-1 looked at the efficacy of atropine versus placebo, which was and other eye was used as control in ATOM-1, and you could see that there was a spherical equivalent in eyes which progression was around 0.3 diopters compared to 1.2 diopters in the non-placebo eye. Now, so they wanted to look at the lower concentration because 1% atropine, though effective, was also associated with pupillary dilation, loss of accommodation, and photophobia. So ATOM-2 looked at the efficacy of lower percentage atropine or lower dose atropine, as we know, and again controls were again historic controls, and corresponding change in the spherical equivalent was around 0.3, 0.4 and 0.5 again. So efficiency was atropine. These studies did prove that efficiency of the atropine was clearly dose dependent, and LAMP study also said the same thing. A LAMP study looked at 0.01, 0.2 and 0.5, and again 0.05 worked the best on best control of progression. And it is also a LAMP study, since there was a washout period, it also showed that progression is again seen after cessation of the treatment, and like efficacy, even the rebound is related to the how strong dose you are using. So what did we learn? That yes, it is dose dependent, rebound on cessation, which is also dose dependent, pupillary dilatation was least with 0.01%, and effect of near activities and accommodation was also less. So that's how we came to this magic number of 0.01%, because it was efficacy wise equivalent but had other less co-issues which were there. Now data from India, there was an IATOM study, which was a multicentric placebo controlled prospective study, again 100 children, and a mean increase in myopia group was 0.616 versus 0.35 in placebo. ATOM-2, which was IATOM-2, or the second larger retrospective study, which looked at 2 years result, and this study was much larger with different 20 centers and more than 700 patients were enrolled, and again mean myopia progression with atropine was much less compared to those who did not, in this study there was no control group, but you could see that myopia progression did reduce at the end of 1 year with atropine. This study also identified that younger children who had received atropine or who had myopia earlier had higher baseline progression and poorer response to the treatment. However, the only one limitation with this study was there was no analysis on the axial length effect of atropine on axial length in India. But still, there is enough evidence to show that atropine does work. Is it universally? No. Well, some 2 studies from USA at the same time showed almost a different result. One CHAM study showed good response, while Repka et al. Have reported that there was not at all effective in the study. But probably there are racial differences and so what about non-responders? So 10 to 15 children are children are likely to be non-responders. However, wait for a year before you label them as non-responders. Options are either doubling the dose or concentration. You can shift to a combination with the myopia control glass or another modality, or you can shift them all over to the different modality, like shifting them from atropine to glasses or ortho-K lenses. Who are most likely to not respond? Who are most likely to respond to atropine, low dose atropine? Slightly older children, and children who do not show progression in the first visit itself probably are going to be likely to show better response to atropine, and you should probably continue atropine for them longer. Pre-myopia, is there a role? Well, Hong Kong studies have and our own Dr. Jethani has also published efficacy of low dose atropine in preventing progression of myopia in children who are not yet myopes but who are low hyperopes for their age, typically the siblings of children. So if you can motivate the parents to get their axial length and you do see a elongation of the axial length or a decrease in their hyperopia over a period of a year, you can look at atropine. There is some evidence that it may delay the onset of myopia. So if you look at the evidence, it is effective, economical, can work across powers and ages, easily available, and dose strength can be titrated, because now we have 0.05 also very likely to be available in India, waiting for DGCI clearance. Is it everything hunky-dory? No, not really. There is some sobering data from patients who subjects who participated in the original ATOM study, which is 20 years back, who are now in their adults. So they went back and looked at those adults now who were enrolled in ATOM 1 and ATOM 2, and they could not examine all patients who were enrolled in those studies, but fair number. And there was no difference in spherical equivalent or axial length in eyes treated with placebo or atropine. This is a little bit sobering data. But remember, those children received atropine only for 2 years and no more than. So all this study, even though it was not sufficiently powered, what it tells is that rebound is definitely catches up. So 2 years is not sufficient, what ATOM 1 or ATOM 2 or what we tend to believe looking at the evidence. Similarly, there was no change in the incidence of myopic macular degeneration or retinal detachment. So was it really successful? This study did not look at with sufficiently powered or all patients. There are problems with the study, but what it does show is that even though you put atropine, you are likely to require it for longer years, and you probably have to think that at some point when you stop, there is going to be a little bit of rebound. And these children, even if they are less myopic than what they would have otherwise, they still need care and attention later on also. Thank you so much for your attention. So this is all I have for atropine at this point. Now coming to myopia control glasses, that is also a recent development, relatively we have much more data on atropine. There are several products mentioned in this talk, but I have no financial disclosure or any financial relationship with any of them. So even though myopia is increasing, if you look at the global myopia control uptake, it is 90% of them still use single vision glasses, and only around 1 to 3% are using myopia control solution of any sorts, not leave alone glasses. So I think this number needs to change as we go further. So looking at again myopia control options, if you look only at optical options, there is ortho-K, there is orthokeratology specialty multifocal soft lenses, there are multifocal and spectacles and bifocal spectacles. So these are the optical interventions which are available for us. Bifocal glasses, peripheral defocus glasses, multifocal contact lenses, dual defocus contact lenses, and orthokeratology. I'm only discussing those, there are more than these, but I'm only discussing which we have it available here for us to use. So if you look at bifocals and progressive addition lenses, myopia is also sometimes associated with higher lag of accommodation, which creates a hyperopic defocus, which in turn acts a cue for axial elongation. And children who have progressive myopia with high lag of accommodation, probably a small subset of children may do better with bifocals. Children who have esophoria for near, also you may look at adding a bifocal component as a myopia control measure. So bifocal glasses do work, but in a smaller subset of patients with these two caveats. Multifocal designs now are in vogue, and there are now several products available in this. So what do they believe in this is, when you give a single vision glass, the central rays, because of the shape of the eye, central rays do get focused on the retina as intended, but peripheral rays go behind and produce a hyperopic defocus, and that is a cue for elongation as suggested earlier. To accommodate these rays which are peripheral and which are going behind the retina, eye elongates to accommodate them. So if you can produce a peripheral zone of defocus to make these peripheral rays artificially myopic, you can have good vision and take away this cue for elongation of the eye. And this is the principle behind coming up with several multiple segment glasses, multifocal glasses, which we are going to see. So first one of the block was MyoSmart, which was by Hoya, and it uses a technology called defocus incorporated multiple focal segments. Basically these are lenses which are there is a central 9mm optical zone, and then there is a 33 millimeter zone of lenslets around which are surrounding the 33 millimeters of the central zone, and they all produce 3.5 diopter myopic defocus. So each at 1 millimeter, each of these lenses produce a plus 3.5 or are actually plus lenses, so that they produce a myopic defocus for the peripheral rays, and that's supposed to control the elongation of the eye as well as the myopia. So first study which came out with Lam et al., who were responsible for designing this lens, and they showed that myopia progression was 0.41 at 2 years and 0.052 at the end of 3 years, which counts to around 60% efficacy in controlling the axial length. If you remember, atropine does not correlate very well, or is not very effective in axial length elongation, preventing axial length elongation, but these glasses seem to are better in axial growth or axial elongation. And compliance was supposed to be good, adaptation to the peripheral blur was very clear, and 70% of the children progress less than 0.25. So this is the first study which came out with DIMS lenses. What is our experience with DIMS? We enrolled around 108 eyes of 54 children, mean age was 11.2 years, and 6 months after starting DIM, the average progression of spherical equivalent reduced to 0.20, and at the end of 1 year, if you do it cumulatively, progression of myopia was less than 0.5, that is around 0.35 diopters. So if you look at it, before starting it was 0.98, and when we looked at it at 6 months it was 0.20, but which increased slightly to 0.35 over a year. Similarly, axial length increase, which was happening at the rate of 0.37, dropped to 0.07, and then slightly ticked up again here, 0.23. So this is our data, not yet published, but this is Shankar Netralaya data with using DIMS, because I have the data only for DIMS because that was the first company which made it available in India. So on an average 59% reduction in myopia progression in 6 months, and 57 if look at 1 year, it comes down to around 57%. How does it compare against atropine? So in short term study, it looks like DIMS lenses work better than low dose atropine. This is the retrospective data from this study, and you can see axial length elongation was significantly lower in DIMS lens group. Then the second thing which was coming to the market was HALT technology by Essilor. It has a spherical front surface with 11 concentric ring formed by contiguous highly aspheric lenslets of 1.1 millimeter diameter. Again, central zone, optical zone is around 9 millimeters, and geometry of the spherical the aspheric lenslet has been calculated to generate a volume of myopic defocus. So it does not have a single point of defocus, but it produces a volume of defocus across the entire posterior pole because of the except for the central 9 millimeter zone. Comparison of DIMS and HALT, only one study by Go et al. And again in this HALT seemed to perform slightly better than DIMS, again with only a 6 months data which is available. The last or the most newest product is by Care Technology using Zeiss. Here again defocus is produced by incorporation of cylindrical annular refractive elements. Two different available options are available aimed at younger and older children. There is a central optical zone which is surrounded by alternative rings of correction and defocus. MyoCare S and MyoCare both are available. MyoCare S is slightly more expensive, but efficacy is being reported in the RO posters which they have presented around 50 to 60% comparable to other two products. The new kid on the town is going to be diffusion optic technology lenses or dot lenses, where there are translucent dots incorporated in glasses. They reduce contrast at the retina, and low contrast is equivalent to stimulating the natural outdoors. This technology does not produce a defocus at the retina, but it modulates on and off pathways at retina using a low contrast stimulus which is produced. There is a 4-year data available, not yet available in India, and effective in both younger and older children, and compared to single vision glasses, dot perform better in this study which has been published in 2023. So what do these myopia control glasses bring to the table? They are safe, they are on the face, so you don't have to worry about putting the drop every day. They are effective, 55 to 60% irrespective of which product you are using. Better control of axial length elongation compared to atropine. Mechanism of action is at least postulated mechanism, makes sense, and it is non-interventional, nothing is going into the eye per se. Concerns, cost and reduced effectivity over a period of time. It has not, there is a kind of a in our small data also you can see that there is a really good reduction in 6 months, and then slightly there is upward bump. So probably if you follow them for a longer period, you may have a decrease in effectivity. Although 6-year data is out and they have not reported any major decrease in effectivity, but there is a little bit of concern there. Cost, now my question is it really a concern? So lifetime cost of traditional myopia management, which is single vision glasses, was definitely more than myopia control glasses or LDA. This is a complex cost effectiveness analysis done, published in BJO. I've get the reference here. Those who are interested can read it. So it was $7,437 versus $7,280. This lifetime cost analysis was done in 2 countries, Hong Kong and Australia, and it was definitely much lower for atropine, but it was comparable to single vision glasses and myopia control glasses. So if you are concerned about patient not affording it, maybe you can use this statistics to help them to confirm. There is another study with Agium. Again, they also looked at good cost effectiveness, and again outdoor activities scored very well on this. Orthokeratology lenses and Hall lenses also worked well. So when patient says, why should I buy these 18,000 glasses? You have to explain that this child is going to need these 18,000 glasses for probably 5-6 years, but benefits are going to last them for lifetime. Do I have time for contact lenses? Otherwise I can stop here.
Yes, ma'am, we have time.
Because thing was only myopia control glasses. But so okay, soft contact lenses and orthokeratology both are specialty contact lenses designed for myopia control. So the only multifocal soft contact lens which has been FDA approved is this MySight or dual zone lenses, which has again a defocus zone, a correction zone in the center, and myopic defocus in periphery. Expensive and not available yet in India. So effective, this is not done in India. This is a company produced, this is a study by Chamberlain et al. And you can see 109 children which were randomized to MySight and single vision lenses, and mean myopic progression in the treatment group was 0.51 compared to the people who wore single vision lenses. So again 59 to 60% reduction in refraction, 52% reduction in axial length elongation. Seed lenses are a extended depth of focus design. Initial trials are promising. More trials are ongoing. In fact, LVP has just published in last year. I should have put that here, but they have again looked at Indian population with seed lenses and good reduction in myopia progression using seed lenses. Orthokeratology, new kid on the block, in the sense it has been on the block for many years, but has probably gained traction again because of availability of better lenses. Previous designs were really not that great, and these are reverse geometry lenses which are designed for overnight wear. They temporarily flatten the cornea when worn overnight, and again it works on reducing the peripheral hyperopic defocus by making a zone of myopic defocus in the periphery. One advantage is it produces a spectacle free, you can be spectacle free up to a certain, say, -6 diopters during daytime, and also works on very good on myopia control. So it not only eliminates daytime spectacle wear, but can also work on slowing axial length elongation. Central corneal flattening is also associated with relative peripheral myopic shift. More effective in younger children and rapid progressors and high myopes. Microbial keratitis definitely in our country definitely remains a concern. Needs an optometrist or a doctor who knows how to fit these lenses properly, because fit is very important and you need a little advanced knowledge to fit these lenses. But very good myopia control in randomized control trials, and among everything probably the best axial length control was achieved with ortho lenses. So these are the various ortho lenses which are available in India, and you can definitely look at in the patients who are interested, especially those children who pursue sports, who are in professional sports. Ortho is a good option. Ortho lenses which were available a decade back probably were not that great, but now I think it's a viable option in a certain, again expensive, but so what are the risks which are across board with all the myopia control strategies? We don't know rebound. In fact, now atropine rebound, we already have Atlas study which I quoted, that rebound definitely happens. Ortho lenses are known to accelerate progression, in fact not just rebound but really accelerated progression. And of course infiltrates and infectious choroiditis is definitely a primary concern. So if you look at the safety, spectacles are relatively safe, no adverse effect. Contact lens wear, safety concerns, fit concerns. Patient education is very important. Patient selection is even more important. Please don't select just because you have option available. Select the patients who are progressing and who really need the intervention. Not every child progresses. Don't miss children with syndromes, subluxated lenses and keratoconus and put them on atropine. Atropine does not work on astigmats and hyperopia, so don't put every child who needs glasses on atropine. So where do we go? As I said, every diopter of control improves quality of life later in life. We should move from progressive single vision glasses to managing myopia, or myopia progression rather. increase options which are there now to choose in coming years, and which is going to increase further. It's a fast changing field with newer strategies, and now we have not just one option but a combination of options which can be, and we should need to be updated and follow evidence based practice. Thank you for your attention.
So thank you, madam, especially for your this talk on myopia control glasses, for which everybody will be having doubts. Probably you can have your doubts personally discussed with madam after this session, since we are running just on time, and so we don't want to create any lack. So thanks to Sumita madam, our guest speaker, and to my fellow speakers, Dr. Reshmi and Dr. Chaitanya, and thanks to all the delegates. And I request Dr. Reshmi to hand over a memento to Sumita madam as a token of the gratitude of KSOS. Thank you, madam.